Hello, I'm Teresa. I'm a physician assistant in neurocritical care. I'm just going to do a little walkthrough on how to troubleshoot an EVD that is no longer working properly. So we're going to assume that it's no longer draining and we no longer have a waveform that looks normal. So the first thing that I would do if I was called to the bedside and told the EVD is no longer draining is to check the actual EVD setup and make sure everything is open in the right direction. So here we have, so the off on these stopcocks are pointed to whatever portion of it we want off. So if you recognize that piece here is coming out of the patient's brain, there's a proximal stopcock here. So as long as it's off to the up position, to the sampling position, it should be open here to run right through. Comes up through here, and it should still be open to go up into the drainage device. So again, we want to make sure we're not obstructed here and we're not obstructed here. So as long as things are good there, the next thing I'm going to do is I'm going to look at my patient's head and make sure my EVD is in fact in place. It hasn't pulled out. The dressing isn't disrupted. It can happen. Sometimes the EVDs can get dislodged. So I want to just take a look at my patient and make sure that it is in fact where it belongs. The next thing I'm going to do, if everything looks good here, is I'm going to come to the drainage system itself. Typically the EVD is going to be set at a pop-off. It may be at 0, it may be at 10, it may be 15 or 20. And even though it has a little scribble through here, we're actually looking at this centimeters of water side. So the first thing I could do is I can drop it to 0 and see if it will drain. And typically you'd be able to see the CSF advancing and dripping, starting to drip in the drip chamber. So if it's not after a minute or so, you're not seeing anything there, I might now go to gravity to the ground and do the same. I'm going to take the whole apparatus down. I'm going to drop it to use gravity to see if we now can get it dripping. We're still not seeing anything dripping in the chamber. We have to assume that it's occluded somewhere. So places where it can become occluded, it could become occluded in the drainage chamber itself. So you could get some clot material in here, anywhere in the tubing here, up to this point, or anywhere in the tubing here into the patient's brain could be occluded. So when it comes to troubleshooting and trying to clear the drain, if we believe that it's occluded, the first thing we're going to do after checking the whole system, checking the patient, is we're going to flush this drain from here through to the drainage system. So from this proximal port out to the drainage system. So in order to do that, I'm going to turn the stopcock off to the patient here because I don't want anything going that direction. I want it to come this direction. And then I'm going to prep this for a sterile flush. So I'm already in my sterile garb. I've got my hair covered. I got my face mask on. I have on my sterile gloves. I have my equipment that I'm going to need, which includes some sterile drapes. So I'm going to use my sterile drapes to come up here around this device. And my goal is going to be to not touch it with my hands that are sterile. So I'm going to ask my patient, if possible, to turn his head away, and I'm going to drape here, and I'm going to drape there. Again, I can access everything here. I can see that it's turned off. Next, I'm going to chlor prep, and I'm going to clean my port really well for 1 minute with my chlor prep. I'm going to get all around in it. So 1 minute of scrubbing, and we're going to leave it 30 seconds to dry. So once it's dry, we can use sterile, preservative-free saline to flush our drain. I don't want to introduce any air. Again, verifying it's off to the patient. I'm going to come down into here, and I'm going to give it a flush, and I'm going to look for it to fill up my chamber over here. And we see it coming. So it's nice and clear. I've cleared all the product out of here. There may have been some blood, protein, whatever in there. So I'm going to do that. Make sure I've got it all open. And now I'm going to turn my stopcock back to the up position, which now opens the system back up to drain. And now I'm going to watch and see, is it patent? Is it start draining? And we'll give it a little bit of time. Again, I could have an assistant with me who might drop it back down, may lift it off of the mount and drop it to the ground to see if we can get it dripping. You know, we can see there's a drop at the tip there, but it's not actively draining. So after we give it a reasonable amount of time to see if we can get it going that way, now we're going to do a more aggressive maneuver, which is flushing towards the patient, or first aspirating from the patient and then flushing towards the patient. So again, right now the system is open. I'm going to turn my stopcock off to the drain. So now this is my port that's open. Everything is still sterile. I'm going to take a sterile syringe, and I'm going to see if I can aspirate anything. It may flow easily, or it might get some resistance. So I'm just going to try to aspirate. Getting a little bit of something, something. I might get, again, free-flowing CSF. I might get a lot of blood clots. I might get some protein deposits, some proteinous materials that have accumulated in here. But I'm going to try to pull back. I'm not going to take a large volume, and if it does flow, I'm going to take it slowly. And once I'm convinced that I've done all I can do here, I'm still hitting a lot of resistance, I'm not getting free flow, I'm going to come out and give up on that. So now the last thing we're going to do is we're going to flush towards the patient. Again, we have to be sure that we're using preservative-free sterile saline. We're going to use the least amount of volume as we can. We don't want to introduce any air. Again, my port is closed to the drainage system, open to my patient. And I'm going to come in here, and I'm going to just see if I can get a little bit to go in. I'm getting nothing to go in. It's like I'm hitting a rock ball. So it may be free flowing at this point. So I might be able to just shoot a cc or two in there, after which I would come back, reopen my port, and see if it's free flowing again. Oh, there's that drop sitting there. I was thinking about it. Give it some time. Still not working. If I was able to administer an ml or two, I could come back and do a little bit more. And I'm going to try to administer a little bit more. Oops, can't really see what I'm doing here. So I'm going to administer a little bit more. Open it back up again, see if it will drain. Again, we could try dropping it down to use gravity. After we've administered probably 3-4 mLs, you're not getting anywhere. This EVD is probably clotted off big time within the ventricular system. So we probably would stop here and notify our neurointensivist that our efforts to flush this drain have been unsuccessful, and we likely will need to then call neurosurgery to reassess the need to place another EVD. There are times when they might consider doing TPA. Again, that's going to be on a case-by-case basis in consultation with the neurointensivist and the neurosurgeon. I would not advocate for anybody doing this without touching base with the neurointensivist first. And you should always write a note anytime that you access the EVD. Thank you.